Hello everyone, I'm Dr. Alexandre Sato, urologist here in São Paulo, Brazil, and today's talk is going to be about active surveillance. So in this video, we're going to be dividing topics like what is active surveillance, what is the criteria for active surveillance, how do we do active surveillance, and what are the oncological outcomes in terms of prostate cancer of a man in active surveillance. So active surveillance is a modality of treatment in prostate cancer where patients in low risk, very low risk prostate cancer can apply to active surveillance. So active surveillance is we postpone the prostate cancer treatments because of side effects like rectal dysfunction and incontinence. So these are the main problems when you are treating prostate cancer with radio or surgery in terms of treatment of prostate cancer. So active surveillance we can offer only for patients with very low risk prostate cancer and low risk prostate cancer. We have a different kind of criteria to active surveillance depending on the service you have. You have the Sunnybrook, you have the Johns Hopkins. So mainly they consider PSA, PSA density, local staging T1 or at the mass T2. The numbers, of course, with prostate cancer, 2 or at most 3 cores, ISUP 1 or Gleason 6. You have the Sunnybrook data that you have patients with ISUP 2, 3 plus 4, or Gleason 7. So depending on the institution that you have different criteria for putting patients on active surveillance. So how do we survey these patients with prostate cancer? So we have a rebiopsy in 6 to 12 months after the first biopsy confirming the very low risk or low risk prostate cancer. And then we have a PSA every 3 to 6 months, a digital rectal exam in 6 to 12 months. In the rebiopsy, you have MRI for guiding and a more precision biopsy in terms of active surveillance. And you can repeat the biopsy depending on the institution in 3 to 5 years, or if you have a change in the data that we have in terms of PSA, density of PSA, digital rectal exam. So if you have a change in this data, you can have another MRI and guided fusion biopsy. So in terms of oncological data, we have a number of series from the Johns Hopkins, the Sunnybrook, with more than 10 years of follow-up patients with active surveillance that we have almost 50% of this population in active surveillance. So, it's still people that didn't have radio or surgery that is still on surveillance. You have data from about 2% of this population with metastatic prostate cancer and about 1% of this population having died of prostate cancer. So it's a very low potential of metastatic prostate cancer, a very low potential of dying of prostate cancer. So if you have patients with very low risk prostate cancer or low risk prostate cancer, the main treatment for this kind of a patient is active surveillance. Of course, if the patient doesn't desire to go to active surveillance, he can go to surgery, he can do radio, but I think the main treatment for this kind of a population, you have data about more than 50% of the population having active surveillance. Is still low because this data should be more than 90% of the population in this kind of a setting to have active surveillance. So, but of course, it's much more than it was 10 to 15 to 20 years ago in terms of prostate cancer treatment. So the data are really big. To have a long-term follow-up showing that it's very, very secure to have active surveillance. And of course, you can just postpone in a very young patient with good sexual function without incontinence. You can postpone 5 to 10 years the consequences of the radical treatment of prostate cancer. So if you have any doubts about active surveillance, just write down in the comments. If you have a patient with prostate cancer, you can share this video to him and help him to decide to go to active surveillance instead of surgery or radiotherapy. So see you soon for the next videos.